We'd like to continue the great discussions we've had from the morning session by moving now into patient navigation for cancer screening. And Dr. Heidi Nelson, who is professor at the Kaiser Permanente Bernard J. Tyson School of Medicine, will be talking to us about new evidence, recommendations, and coverage. And I just want to share that Dr. Nelson brings considerable expertise in clinical epidemiology, population health, screening and prevention, women's health and healthcare guidelines and delivery. So just in line with keeping with making sure our conversation here today is sort of puts us on the path to continued action, her research is really focused on connecting research and clinical practice. So I'm going to turn the podium over to Dr. Nelson to have her to share.
Thank you. It's great to be here this afternoon. What a wonderful morning that was, huh? So hopefully you'll see some relevance with the information I'll give you in the next few minutes. We're, I think, now in a series of shorter talks, so I'll keep my eye on the clock here. But as introduced, I've worked at the federal level in developing guidelines for clinical care, especially involving screening and prevention. Let's see if I've got this one down. At the beginning of all our talks, we are required to disclose our financial arrangements, but mine are all federally funded until we were shut down. That is, the research I will describe today was funded by the Health Resources and Services Administration, other funding also from the Agency for Healthcare Research and Quality, no commercial interests. I am going to go over very briefly how the evidence connects to create a clinical recommendation which leads to coverage. And as beautifully described earlier today, coverage is a huge barrier. If you're not getting, if patients have to dig deep in their pockets to pay for something, if clinicians don't get funded for doing something or others in the health system, it's a real barrier. It's an important barrier in our health system. So how these things connect is very important to having them actually get done. So you are mostly probably working in more the treatment end of the spectrum when it comes to cancer, but and maybe unaware that there are several federal guideline groups for preventive health services. And these became even more elevated in their importance in the passage of the Affordable Care Act back in 2010, which mandated insurance coverage in both private and public sectors. So well-insured private coverage is obligated at the same level as public insurance to cover, with no copay or deductible charges, screening and prevention services that are proven with evidence to be beneficial. And there are 4 groups. Today, we'll see if these are just kind of slowly starting to disappear, but this is a story today. It has been for the last 20 to 30 years. The U.S. Preventive Services Task Force, which I worked with for over 20 years, housed at the Agency for Healthcare Research and Quality, develops practice guidelines for all kinds of populations. The Bright Futures group, which is sponsored by the American Academy of Pediatrics, but also through HRSA, develops recommendations for children. And then a group I've been working with for the last 10 years, which is specifically focused on guidelines for women's health care that falls through some of these cracks from the U.S. Task Force and Bright Futures, called the Women's Preventive Services Initiative, administered also through HRSA. And of course, you've heard of the Advisory Committee on Immunization Practices supported by the CDC, which has just been revamped and may have a different role in our diagram here in the future. I can't say, but they provide guidance on appropriate immunizations, all based on evidence, and they'll have rather rigorous, transparent methodologies, so we can all see how we got to the recommendations. So these groups provide preventive service recommendations that are then mandated for ACA coverage. So it's all very connected and very much has been in place, certainly since the ACA in 2010. But some groups like the U.S. Task Force, I started working with them in the late 90s. They actually began in the 80s, so they've been around for a long time, as have Bright Futures. So it's important to know how that is, because that's how policies get made, and insurance coverage is mandated in every state. So it's great that states like California, my home state of Oregon, has a number of things that cover screening for cancer with no copays or deductibles in place, but those can be quite spotty across the country and aren't uniform in that way. So a federal policy is all-encompassing and involves everyone. It's most equitable. All these things are helpful. So I'm going to walk through the two examples of breast and cervical cancer screening because they're most relevant to what I've been doing. We did get to the point of new recommendations in the last year and 2 years, and they involve patient navigation. It seems that lung cancer falls right along this trajectory. So I hope there may be things that can be taken from this example. If we look at just straight up screening rates for breast and cervical cancer, they don't look too bad. The goal is 80%. If we look at all groups, we're getting kind of close to that. If we look at the usual inadequate sociodemographic groups from the latest information I had, not too bad. There's some differences. We should get that all on the same page. But it really depends where you shine the light. A study came out of over 1 million patients in federally qualified health centers, a different spotlight than what we usually see in some of this other population data. And their rates were terrible. At 45% for breast cancer screening, 51% for cervical cancer screening. In the general US, those levels are a lot higher. So we're not there yet. So we aren't getting everybody screened. But there's more to this issue than just getting that mammogram and getting that cervical study. I'm laying out a breast cancer screening clinical pathway. The others are kind of similar. You're more familiar maybe with some of the others. Usually in screening, we start with one thing. So here you get someone in the door, and we do routine screening, maybe digital mammography, maybe tomosynthesis. That's become more common. And if you're lucky, a lot of women, they just have a normal result, they leave, and they come back in a year or two, and they go in that little circle pathway back and forth. But for 50% of women over 10 years, they have to come back for another image. It's very common to come back. It doesn't mean there's cancer. It means we need to take a better look. So there's additional imaging, and now there's more than just a few things that you can, we used to come back and get a special view. Now there's tomosynthesis, ultrasound, MRI, other kinds of views, combinations of things. And again, if you're, that kind of helps sort out who needs a biopsy, who doesn't. And if you're lucky, everything in the end is normal, you'll go back into that, circle up at the top. But for most people, they don't need a biopsy, but quite a few people do at this stage. Some people need a biopsy. And that is going to have, but some people just, maybe they don't need a biopsy, but they aren't going to come back in a year. Maybe they can need to come back in 3 months, 6 months. They need a little more closer monitoring. And those with a biopsy, of course, this is the whole goal. We want to find someone with cancer and treat them early. But actually, most people don't have cancer. So this whole thing happens, and most people don't have cancer. We also found, not only do we get everybody in the door at those federally qualified health centers, we have high losses to follow up once you start this process. These are studies, meta-analyses of studies in the US, very different than Europe, where everybody comes back. It's set up entirely differently. Up to 33% lost to follow up at 3 months in those studies, up to 71% at 6 months. They don't come back. There's a huge sieve there. And so that's a problem. So drilling into this literature a little bit more, the usual suspects, right? An inadequate healthcare system with communication support, lots of logistic barriers, that whole insurance coverage. The ACA only covers the first study, not all the other ones. So things start adding up for people. The cost sharing, even if you have, you think you have good insurance, you still have to do the cost sharing or the deductibles. It gets to be quite a bit of money. And then if you do drill down into certain groups, it varies. And there are very few studies beyond kind of the major groups we look at, but there are some real holes in the system. So we know we're not doing a good enough job, and I like the idea that if we fix this, we reduce deaths probably more than the most elegant new therapies we can think of, right? We get people in the door quickly, and we get them through the process quickly so we can find those early cases. So taking a big step back, we did a project for the NIH on reducing health inequities in preventive care, and we created this diagram to kind of really show how complex it is, in the sense that you get someone in, if we follow that line along the bottom, we're talking about a preventive service pathway. The first thing is to get in the door, so that's one issue, important, those screening rates. Then you figure out who's eligible, usually based on age, sex, or some other big thing. You get the screening, and you might just go back into the pool and come back another time, or progress to a follow-up test, the diagnosis and treatment, where most of you in the oncology world come into play, and you have these wonderful navigation systems and processes in place. People head on down that route. If we look across that trajectory, they can also reimpose on top of it a series of levels of influence: societal, health system, clinician, down to the patient level. There are other influences that get us to each of these places in the arrows. And in our general earlier scope of screening, when I worked with the U.S. Task Force, they wouldn't budge from this. Yeah, we go up to the screening test and what that shows. That's it. Everything else is diagnosis. But if we look at the broader view, the expanded scope, where screening is everything up to the diagnosis. It's all the things I showed you at to the biopsy, right? Because you don't know, everybody else doesn't have cancer. And so we can also expand a little beyond the health system. When working with HRSA, they want to deal with health systems. But we know that some of the projects some of you are involved in involve the communities and interacting with the communities as well. So I don't want to leave them out, but for the purposes of HRSA and the ACA coverage and all of that, they really look at health services, but we can enhance those with looking up higher at the societal level of our patients. So we took an expanded view this time, and we did something different. We created recommendations for breast cancer screening to the point of diagnosis and cervical cancer screening to the point of diagnosis. And the breast cancer screening recommendations were approved last year. They are actually active today. A lot of people don't know that. Those are no copay or deductibles for biopsy, repeat imaging. It's live. Cervical cancer screening guidelines were just approved in the waning hours of 2025, and it takes a full year for them to be actually enacted financially. But they are both covered now. So that's incredible. So here's what we wrote. We decided that the screening effectiveness of breast cancer would be better improved with better delivery and coverage that are for those services that are already recommended by our guidelines. So we wrote it as trying to be complete, but yet we can only have a sentence or two for HRSA. They really want to get to the bottom line. So women may require additional imaging to complete the screening process or to address findings on the initial screening mammography of additional imaging, MRI, ultrasound, mammography. These are just examples. And pathology exams are indicated. These also are recommended to complete the screening process. They are covered. Just for completeness, these are the other parts of our breast cancer screening recommendation. We didn't change them. The data and the evidence really indicate you should start no earlier than age 40, but no later than age 50. And between 40 and 50, it really breaks down to your preferences and your risks biannually or as frequently as annually. The data don't show us what's better, and again, it might break down to breast density or other factors. There's no good age to end. Age alone is not the basis to discontinue. And women at even higher risk should get at least this level of care. And then we refer them to the NCCN guidelines or others to talk about, BRCA carriers and others at high risk. Those are all covered. So for cervical cancer screening, we wrote a very parallel statement about extra testing and pathology evaluation. Those are covered. And this time, the only other change we added was that patient-collected HPV testing is an appropriate method. So that would hopefully open it up to others who may find that acceptable or easier. And so that was just approved. So here's cervical cancer screening. So I would envision if the U.S. Task Force, they haven't had a meeting in a year now, but they could take on lung cancer screening and expand it in this way. Colon cancer screening has already been expanded by HRSA up to point of biopsy, but not lung. So we'll see if that can happen. But we thought, okay, they didn't come back, even if it's covered, that's only one of those barriers. So let's add a new recommendation on patient navigation services for screening and follow-up, not what, you have great services for later. And indeed, this sounds like I picked up a brochure of screening navigation. It's already happening in places like this. But most places, this is not happening. So our usual way of doing this is to round up the research and provide the evidence for something new. So we did. We did our usual review of the evidence, doing a systematic review, following protocols. We had over 1,400 abstracts. We ended up with 42 randomized controlled trials. And so we had 42 trials that showed us screening in different populations. Advisory or the recommendation group is really interested in, like, does this only helpful in specific groups or in general groups, or what other kind of groups? So we were able to cluster those trials among a general population, a big health system study, low-income study, maybe those federally qualified health centers had studies, or others. So they were patient selected for a language issue or a certain demographic, or they kind of clustered into a category of other. And we had trials for cervical and breast cancer in all those populations. So that helped justify how to put together a recommendation. What kind of deliveries occurred? As you know better than most, those of you doing navigation, there are all kinds of things that can happen. And so the delivery in these studies was by a number of different personnel, navigators. They just called them that. We tried to use the words that were in the trial: telephone counselors, patient navigators, care managers, social worker, lay worker, promotora, the study team. The services included variations of what we see up here: reminders, referrals, contacts, financial information, transportation, scheduling, education, other. And by other, some of them had workers escort women into their mammogram and wait with them. Those kinds of things were unique, but were in some of the studies. So the studies are really, really different from each other. But the lovely thing is they all worked, no matter what the population was, what the service was, who did it. When you compared the intervention of patient navigation with usual care, what typically is done, they all worked. So this may be over technical for some in the crowd here, but this is a forest plot. A lot of people like to see these, and what threw me into an excitement after we got this together is how they all line up. The line down the middle, the hatched line down the middle on the far side, means no difference. And anything, towards the edge of the slide shows benefit. And anything short of that, on the other side of the line, shows no benefit. They all went on to the side that shows benefit. And when we put them together statistically, we saw 50% higher screening rates in that rate ratio, which is what the statistics we do to combine the results. So if we looked at predicted rates over a 1-year period, it would be 39% of patients without navigation versus 53% with navigation. For follow-up, we only had 3 trials. It showed 78.5% follow-up without navigation, 96.1% with navigation. And we looked at the different populations. I know you can't read this, but I just want to point out this is the general population. This is a low-income population. These are the other selected ones. They all did the same thing. It works for everybody in all these different environments. So that was a nice, simple answer. It works for everybody, no matter what you do. It works. We did the same thing for cervical cancer, and the results were very similar. Here's general. We had fewer trials. We had a total of 20 for screening and 2 for follow-up. Here we go, and the results are an improvement. We couldn't, with only 2 follow-up trials, we couldn't combine them statistically, but there they are. So that's how you change policy. You have to have data. So if some of you are doing this already with lung cancer screening, start collecting your data and get those studies together, because we didn't find much for lung cancer screening at this point. But that's what changes things, data. So we found you can reduce the barriers to screening and follow-up. They vary by delivery and types of services. Of course, they're individualized to patients' needs. And so we saw higher screening rates in all those populations. We have a new recommendation. It was approved last year. It's active right now. You can bill for this. Patient navigation services are recommended for breast and cervical cancer screening and follow-up as relevant to increase utilization of screening recommendations based on an assessment of the patient's need for navigation services. HRSA added this other language, so it's parallel with those other 21 chronic conditions that's what were mentioned earlier this morning, because they do cover navigation for some chronic conditions now, including cancer. But this is the first time they're covering it for screening. And again, yes, it can actually apply to prostate and lung and colorectal. We just don't have them yet. So let me show you. In a different project, we looked at trials for colorectal cancer screening and found a very similar increased rate among those. But there aren't enough studies for lung or prostate cancer screening to push everyone over that line. So that's where we need something to do that. Why would they be different? You know, I'm sure it works there too. So I'll stop there. I'm running out of time and see if there are any questions. But I just want you to know there was very little fanfare, very little press about this. But I think it kind of changes a lot of things. I guess we're all distracted by other things in the world, like wars and sad things. But this is going to help a lot of patients, and CMS and HRSA are working out how to bill, how to actually do this. So some of you have examples of how you've done it successfully. Write it up as a case report so we all can learn from you, because there's a lot of confusion in many areas. They aren't all as well connected as what you have here or in places like this. So I'll stop and see if there's questions. I know we need to move on to the next one.
Any questions?
Thank you for a really great presentation. I mean, one of the things that I think about, and the lesson that I'm taking from what you presented, is that there's a long process of getting something to a place where it's recommended. Not only is it recommended, but there's payment for it, and that's part of the policy. And so if we think about lung cancer screening, which is relatively new in terms of its availability, I think it was first introduced into the Preventative Services Task Force with the grade B recommendation, maybe in 2013, 2014, around that time. So it hasn't been available for that long of a period of time. And I'm wondering, thinking about breast and cervical cancer screening, which has been like decades and decades, what do you have recommendations for how we might accelerate the generation of the translation of the evidence that we know about lung cancer screening into coverage, better coverage, and into approved coverage for patient navigation within the context of lung cancer screening? Because I feel like, if we're going to, if our trajectory is that we're going to have to wait like 30 more years, then we'll be too late, right?
Yeah. Well, we kind of have a system all ready to go, because as long as the ACA stands, a preventive service recommended and accepted by HRSA will be covered with no copay or deductible charge. And the one reason we're able to expand the coverage for breast and cervical was because we said, look at colorectal, that's what they do. And they approved that the year before we got started. So there's a real trajectory now that's quick. So I think if we could get that together, if I were on the task force and I went to meetings there for 20 years, I'd go, we don't have to do all these trials. We know it works for these other cancers, but they do have to have something. So that would be nice to have, fill in the blank a little. And I haven't looked for the last 3 years for lung or prostate. That was an older set of work. Most of the trials I showed for breast and cervical are fairly new too. Although you're right, it's been around longer. So I think it's just set to go. So, but it would have to be the task force because it's out of the scope of our group. Yeah, great. So take them on.
Thank you.
Please leave comments. Use the QR code that's in the middle of your table. Thank you.
Thank you. So, I'm really excited about the conversations that we're having this afternoon because we heard a lot this morning about the reason why, but now I think we're moving into the space of how. And with that, I want to invite Zul Surani to the podium. Zul is the Associate Director for Community Outreach Engagement and Partnerships at Cedar-Sinai Cancer Institute. And he also serves as the administrator for the Research Center for Health Equity, which focuses on health disparities through research, service, and policy in Los Angeles and statewide. So, Zul, please.
Thank you so much. And thank you for the opportunity to the Planning Committee for inviting me to speak. So I'm going to talk about Faith in Action, which is a faith-based, church-based navigation model to increase breast cancer screening amongst Korean women in Los Angeles. So I want to start with our catchment area. We serve a really wide catchment area. We just added 4 new counties, Kern, San Luis Obispo, Santa Barbara, and Ventura to our LA County. And our catchment area consists of 12.4 million residents. And overall, we have a higher proportion of Hispanic Latinos and a high proportion of immigrant populations. A third of our catchment area are immigrants. And so we are in a unique position to drive impact in diverse populations to address the cancer burden rates. Our catchment area has a higher proportion of populations covered by Medi-Cal and living under the poverty level compared to California. And so this provides an opportunity for us to bring high quality healthcare services and resources to underserved populations. And so we've developed robust partnerships with 171 community partners throughout our catchment area. You really can't do this work without having strong, mutually beneficial partnerships. And these partnerships that we've developed are trusted in the community. They reach underrepresented populations, and they've also enabled us to launch impactful cancer prevention and research initiatives. And partnership development takes a really long time. We also have a 20-member community advisory board that also advises us on how to launch and sustain programs. And so, in looking at LA County with over 10 million people, some distinguishing populations is that we have the second largest LGBTQ plus community in the country, and that Filipinos and Koreans are 2 of the 3 largest Asian subgroups in the catchment area. In fact, we have the largest Korean population living in our catchment area outside of Korea. And so our maps, we created these maps where show us where these communities reside so we can focus our interventions at the neighborhood level. And I think Dr. E talked about it earlier, that it's really getting into the neighborhood level and looking at the structural barriers that are happening in local neighborhoods is really one aspect of addressing the needs of our communities. So the communities that we serve experience a lot of barriers, right? So low screening rates, lack of culturally appropriate cancer materials, lack of health insurance, and lack of navigation. And this is really upstream. Cultural stigma, historical mistrust, fear of cancer outcomes, and also fear due to immigration status. I mean, this is something that we're dealing with today, right now. And so we've developed and maintained a network of trained community navigators and promotoras in our catchment area. And again, we've really done this through partnerships with other organizations that have promotoras, and we've trained them, and we continue to fund them through mini grants. And so that has been an amazing way to start our work. And this was in the Latinx community. And our goal is to scale this network throughout our catchment area because it truly works and it can address the cancer continuum. What we've also done is worked with the navigators to build the cancer continuum in different neighborhoods. So starting with prevention, detection, diagnosis, treatment, and survivorship. So really developing these partnerships and bringing them to the table. Like, what are the local FQHCs that work with the community in this neighborhood, and who's providing the screening, and who's doing the education, who's providing support services, how do people access transportation, bringing all of that together in a neighborhood. But really the vehicle has been the community health workers, the promotoras. And so one of the things that we also did with the California Cancer Registry, actually it was the LA County surveillance program right here at USC, and this is a while back, is they helped us map late-stage breast cancer diagnosis in LA County, and we saw Koreatown light up. This is where we saw the highest disparities in late-stage incidents, and so this actually helped us galvanize the community, but we really didn't know why, and so we conducted a local needs assessment survey in Koreatown of the Korean community in language, and found within this neighborhood only 41.3% of the women were compliant to breast cancer screening recommendations. And when you compare it with other populations, it's in the 70-80 percentiles. So, this was really a big eye-opening statistic for us, and we brought it to the community immediately through media events, and used that as an opportunity to build a community advisory board of the Korean community that was concerned about this issue. So, engaging community at the grassroots level, bringing them to the table and working with them to say, and of course the question was, what should we do? And so, we turned to what's evidence-based and strategies that are impactful at the community level, like group workshops, one-on-one cancer education, use of tailored materials, but a really important one was community cancer navigators, community health workers who address barriers that women have to getting to where they need to get to. In bringing this group together, they're the ones who, bought into this approach to having this multi-level approach, although the idea of community health workers was new to the Korean community. So they didn't feel like they really had this role. And what we also did was we worked with community leaders to develop and adapt materials for community health workers for the workshops, the presentations that were done, and that took a while because we had to do focus groups and change the curriculum that we had and bring it back and revise it several times until we came up with what was acceptable to the community that the community could use, and that served as our 2-day navigator training curriculum that was comprehensive, that was in Korean, that was delivered in language. And we used the curriculum to launch our tailored navigation and screening. So just to backtrack, a large group of community organizations that came to the table were faith organizations and faith leaders. And what we also discovered was Koreans, 70% of Koreans go to church every Sunday. And so we felt that that was the opportunity to deliver behavior change interventions because we had to do it over and over again. It was going to take time. We had to accept it. And so we developed this curriculum keeping that in mind, that we would want to deliver it in faith settings. We also looked at the local health ecosystem and brought the ecosystem together for the health ecosystem for the community and the navigators. We brought all the partnerships to the table. I talked about this earlier, but really naming them, bringing them to the table, having them present to community leaders about the services they provide. So that also took time. And then even thinking about the cancer continuum as well. One thing we discovered was a gap in survivorship. So, we had navigators in the community, we had early detection programs, we had, places where people could go for diagnostic, workup, treatment, but survivorship was missing. And so we actually did work with community leaders to develop the survivorship component. It's still ongoing, but it's about to launch soon. And trained community leaders and navigators on, what it means to go through this breast cancer screening clinical pathway so that it's transparent, everybody knows what to expect, and it takes a village to help everyone get to where they need to go. And so we decided that, we wanted to wrap this intervention in research, and we brought researchers to the table. At that time, Dr. Robert Hale was at Cedar-Sinai. He's now at Moffitt. Allison Herman from UCLA, who has a background in implementation science, and then Dr. Gresham, who's a trialist, and she also came to the table. But we also brought community leaders to the table, community navigators, to actually work on a research project. And so we took this intervention and developed it into a research study that was funded by the California Breast Cancer Research Program to test this strategy in the Korean community. And in the past, we had done a lot of workshops. We had trained community members as navigators. We'd reached a lot of women. So, we already had the foundation laid for the study. And so the idea was that navigators who are volunteers in churches would be individuals who are volunteers in churches were trained as navigators, and they're the ones who actually implemented the intervention. They conducted workshops, they addressed barriers that women have, and we also leveraged the pulpit for messaging, and that was really, really also impactful. So what we found is through this study of 24 churches, we found that 235 women were not compliant to screening recommendations. We had a 97% retention rate in the study because it was community-led, community-driven. But what we found was women in the intervention arm were 3 times more likely to get screened for breast cancer than the control arm. And we are publishing these results, so I'm not going to share all the details, but it was very, very impactful. And so, so this is something that, we are looking to scale up now because of the impact it's had in the Korean community. And so we rebranded Faith in Action into United in Faith Health Action in Communities, simply because Faith in Action was already taken. And so we had to rethink how we're going to do this. And so bringing together all the resources within the intervention under this new umbrella is our big opportunity to be able to scale up this really impactful intervention. So really our goal is to, expand it to 50 churches in the Korean community throughout the region, from LA County to Kern to Ventura, all the way up to Santa Barbara, and eventually tailor it for other communities because it has been very impactful, and we'd like to see if it's going to work in other populations, and what if we add additional cancers like colorectal, prostate, and lung. And so, Faith in Action, United in Faith, has been a huge learning experience for us in terms of, starting navigation upstream in community settings to be able to really drive community members who are non-compliant to cancer screening recommendations into screening. And so, the question is, how do we apply this to lung cancer screening? And so we've started identifying neighborhoods that are at high risk, where smoking rates are really high and lung cancer rates are higher. And of course, South LA lights up, San Fernando Valley and other areas like Antelope Valley. And, again, we developed a partnership with South LA FQHCs, in fact, with Dr. Christopher Lee, who used to be at USC, is now at Cedar-Sinai. And we tested a pilot project with Watts Health that was very impactful. But when we tried to scale it up, it didn't really work. So we really needed implementation science people at the table. And so, moving forward, we are going to, work on that with Dr. Jen Sway and others. And we also have this vision of building a mobile lung cancer screening van, because again, this was the idea that came from the community, where they felt access continues to be the issue. We can educate individuals, we can get them motivated to get screened, but it's very difficult for people to get into screening facilities, especially in places like South LA, where transportation is a challenge. And we try to do that. We try to bring people to Keck Medicine of USC, and it was very challenging. We provided Uber Health vouchers, and people, it was difficult. So taking the service to them is where it's at. And we have this vision. We're raising the funds. I know we're gonna do it. And what we did is we actually looked at model programs across the country for lung cancer screening. And West Virginia University has an incredibly successful program. They now have 3 mobile vans. 2 of them are lung, 1 is breast, and they serve the entire state. And their model is very much like we're envisioning it, a partnership with FQHCs, and it's been very successful. While treatment is a challenge for a lot of individuals in rural areas, and they're addressing that, but it's been a very successful program. Their mobile van was very expensive at that time. The prices have come down now because technology is better. And so, I feel like we really can make this happen in LA. I spent a whole year with stakeholders within our cancer center, within our institution, to really come up with an operating structure and plan. Radiology is on board, which was a big hurdle, but eventually they came on board. And we mapped it all out internally and externally to see how this could work. So we have an operating structure, we have buy-in from different divisions and departments. We now need to be able to make it happen. So yeah, that's the overview of our navigation program that's embedded in the community, and how we want to translate this to lung cancer screening as well. So thank you very much. I'm happy to take questions. I want to mention one thing is funding is challenging for community health workers and promotoras, and that is something that we keep exploring. Right now, we're lucky that our community benefit department is giving us small grants to be able to give out to the community to sustain this initiative, but we think in the long run, it's really going to be challenging.
Any questions?
Great presentation, Zul, as always. Great to hear about this project and this initiative. Is this on? Okay. I wanted to actually ask this question earlier with Dr. E and Dr. Cummings' panel, but you already brought it up, so I want to continue the conversation here. This aspect of sustainability, I think, is so important. I know there's so much going on, there's so much energy today, and it's going to carry us throughout the year until we meet again next year for this symposium. But what would be our short-term sustainability needs? I think long-term, maybe it's payer and policy, but if we think about the short-term funding needs, even with just this program, Zul, what do you think we need to do to sustain it?
Yeah, I really think this makes a big impact, in local communities, and for community hospitals to invest in this as well, because this is the type of infrastructure that is needed to address so many issues, right? From cancer to heart disease, you name it. So I think given that most hospitals have community benefit requirements, that's one aspect. But I'm also hearing that the state of California now has a CHW funding mechanism that's out. I just saw that the other day. And of course, some of it is funded by Cedar-Sinai. I just didn't know about it. So, it's really, yeah, we have to mobilize at least community hospitals to start out with, because we've tried foundations and, it's difficult.
Yeah.
Yeah.
And I think that really connects to what Chris Straff was saying earlier of reaching outside of our cancer world and
Yeah.
our sort of own networks to figure out where the money is,
Absolutely.
where the funding is.
Yeah, yeah. Well, thank you very much. Thank you.
So thank you so much for that great presentation. I mean, one of the things that really resonates with me is that, we're really wanting to learn from the lessons from other disease sites and apply them to the work that we're doing within the space of lung cancer. And it's so important because, I don't think we have time to really recreate the wheel. So part of the discussion today, I'm sure you're like, well, why are we talking about breast and cervical cancer now? We're talking about them now because they really, there are lots of lessons and lots of evidence that's been generated. And we can really learn from the previous history and apply them to lung cancer. So thank you to the two previous speakers for sort of setting the framework. I'd like to now move us to our next presenter, who is my colleague, Dr. Mario Espitia, who is the Clinical Operations Manager at the Ralph Lauren Center for Cancer Prevention, which is at USC Norris Cancer Center. And Mario's going to talk about, what we do within the center, but I think, it's really just relevant for our conversation today because, I think as we've heard many of the barriers, we focus specifically on addressing social barriers across the cancer continuum. So Dr. Espitia.
Good afternoon, colleagues, and thank you, Shanita. Thank you, Trista, for inviting me today to speak on what we've been doing at the Ralph Lauren Center for Cancer Prevention. Let's see if I know how to use this. The green button. There we go. But before we get into speaking about the Ralph Lauren Center, I would like to start sharing a story that is very common among our patients. I'm a licensed clinical social worker, and I've worked in the healthcare space as well, providing direct psychosocial services. And so I want you to meet Maria, who lives in Los Angeles. She's in her mid-50s. She is very busy working in her local supermarket, and so she's been really caught up in that work, also taking care of her elderly mother. And so she's unfortunately late to her breast cancer screening, overdue for about 3 or 4 years. But when she finally did go to a medical checkup, she went through the mammogram and through the diagnostic testing and was unfortunately told that she had breast cancer diagnosis. She was shocked, she was fearful. She had so many concerns, and some of those included, well, what are the next steps in my cancer care? Even though they were shared by her primary care doctor, her mind went blank. So she was thinking, what's next? How am I going to access my care? I don't have a car, I use public transportation. Where am I gonna go get my care? She was also worried about her job. How am I going to maintain my job if I need to go and get my treatments? I'm not going to have the income to pay for my rent, for our daily expenses. And also, how am I going to care for my mom? She is the primary and only caregiver for her elderly mother. So as we think about Maria and many other people like her, it was important for us then to develop an ecosystem for healthcare navigation services that, one, allowed us to identify who are those community members that could benefit from our support, and two, developing a framework or setting a system in place so that our navigators can move forward with providing services, and they have all the as many resources as possible to go about their daily work. I'm pointing it at every direction here. The one in the top. There we go. There's so many green buttons on there. Alrighty. So this is an example of, or a visualization of the ecosystem for our Ralph Lauren Center healthcare navigation services. There are 6 elements or pillars on here. There are more, but I wanted to highlight what seem to be very vital and essential to our ecosystem. That includes designing a navigation infrastructure, which I'll get into in a few minutes, building formalized community partnerships, identifying those social and supportive services, not only identifying them, but vetting them, digital integration, taking a patient-centered approach, and also engaging and living within the culture of multidisciplinary team collaboration and communication. Our ecosystem is also designed and supported by our mission at the Ralph Lauren Center, which is to enhance uptake of high-quality cancer screening services and improve access to timely cancer treatment through patient navigation. So our first pillar, which is where we design and built the infrastructure for our navigators. We started off by thinking about and developing what is the scope of the navigator role and establishing what is the scope of our services. And so to support that, we tapped into the Oncology Navigation Standards of Professional Practice that was developed in 2022 by the Professional Oncology Task Force. In addition, we developed referral workflows. This helped us define which community members will benefit from our services and which populations we will be serving within Los Angeles County. Lastly, we took time. We were very diligent about developing screening and care plan templates, screening for social determinants of health. And our templates were modeled after existing evidence-based screening tools. Talk about not reinventing the wheel. And those include the Prepare screening tool and the AHC health-related social needs screening tool by CMS. The second pillar to focus on today is the importance of formalizing community partnerships. And so we identified reputable organizations, FQHCs that are already leaders within the community, and that includes Universal Community Health Center, Chinatown Service Center, and also tapping into Keck Medicine of USC. And what helped us throughout this process of formalizing our partnerships was to establish written agreements. And those written agreements included elements such as how the patients will be identified even within the FQHC clinics, within USC Norris. It's also identifying the location where navigators can meet the patients. We realize that it may be difficult for patients to come to us here at USC Norris, especially, I mean, we're a far ways apart from some of the communities, and we also have parking fees. So where can we provide care where it's going to be the easiest for the patients to access our navigators? And also, we worked with our partners to establish mechanisms that support communication and collaboration with all the other healthcare providers involved in the patient's life. So we integrated ourselves into the organizational policies, procedures, and systems of our partner organizations. And that includes receiving access to their EHR platforms, et cetera. And last but not least, the third pillar is multidisciplinary collaboration and communication. I actually feel this is a very important one, if not one of the most important ones, where we really foster that culture within our team. So at USC Norris, we identified oncologists, nurse practitioners, nurse navigators, social workers who can be champions of our RLC program. And an example of that is working with colorectal clinic to embed a brief social determinants of health within their current existing screening tool for geriatric patients. And thankfully, through those brief SDOH screenings in the clinic, the providers have been able to identify patients who are facing social barriers in a more intentional and proactive way, and then referring those to our Ralph Lauren program. The second thing that I'll note here is that we also host a multidisciplinary navigation forum at USC Norris, again, where we, on a quarterly basis, and again, we invite oncologists, nurse practitioners, nurse navigators, social workers. It's an opportunity to highlight the interventions being taken by our navigators, to speak on the challenges that patients are facing and how we can work together to address those. It's also an opportunity to educate other team members on the roles and the scopes of practice of all the other types of navigators, whether it be like patient navigators, social workers, nurse navigators. So with these three pillars in mind and all the other aspects of our ecosystem, we were able to launch our services in April of last year. And we've designed a program where we support our community members and our patients throughout the cancer care continuum, through prevention, screening, detection, diagnosis, and treatment. I didn't include it on here, but we also are supporting community members who are in the survivorship stage. So at the prevention stage, we're engaging in community outreach and education efforts. We attend community events, health fairs, and we're there to spread the word, share information on cancer screening guidelines, healthy behaviors, and cancer risk factors. We educate on the benefits of early detection, and we share cancer-specific information as well as information on our navigation services. Through the screening, treatment, and survivorship stages, we are engaged in providing healthcare navigation services. As I mentioned earlier, our navigators conduct a social determinants of health screening to understand the patient's needs. These are the 5 areas that we're screening on: their social history and support network, housing needs, financial and basic household needs, transportation, social and emotional health. We then work with the patient and collaboratively design and develop care plans. We let the patient take the lead in identifying what they want to prioritize as part of their navigation care. And then the navigators research and connect the patients to those community resources. Since launching in May 2025, we've received over 300 referrals, and this is sort of a percentage division of where our referrals are coming from, and they're pretty equal among all the referral sites, which is USC Norris, Universal, Chinatown Service Center, and some of our referrals are also coming through the community outreach and education efforts. Among our patients, there are 25 types of cancer overall, but the top 5 cancer types among our patients are breast, lung, leukemia, rectal, and colon. Also within our patient population, there are 10 types of barriers that are preventing them from accessing their care. And those top 5 are financial insecurity, transportation barriers, health insurance issues, either no insurance or underinsured, health literacy, and housing insecurity. And last but not least, I'd like to introduce you to the Ralph Lauren Center team, the ones who are living within this ecosystem, all contributors to the development of the ecosystem and implementers, starting with our director, Shanita Hughes-Halbert, our project specialist, Yuvia Nunez, and our healthcare navigators who are over there. Don't turn around. Loan Chung, Stephanie Cruz, Camille Frost, and Vanessa Naredo. But I also would like to acknowledge the early contributors to the development of our ecosystem, Trista, Grace, Kelsey, and Jennifer Sway. Lastly, I'd like to thank the Ralph Lauren Corporate Foundation, who has provided the financial support to develop our ecosystem and then to go beyond and provide the support to the community in the County of Los Angeles. And with that, I end my presentation. Thank you so much for this opportunity. And I'll take any questions you may have.
We have time for 2 questions. We have 1. Anybody else?
Hi, thank you so much for the presentation. I just had a question with respect to whether you also work with MLPs, like legal partnerships. As I sit here as a lawyer, listening to a lot of these issues that are bubbling up, there's protections under the Americans with Disabilities Act for cancer patients and, California-based protections that go above and beyond the federal protections. And I'm just wondering if you're, as a navigator, also, steering patients towards some of the legal aid groups here in California that sort of focus on this area. I work for an organization called Cancer Justice, and I run a national helpline, and all I do is talk to cancer patients all day long around these areas. And so the law can be used as a vehicle to sort of support their rights in a way that, may extend or just go hand in hand with a lot of social services that are available as well. So just wanted to kind of ask your opinion on whether you do that within your program.
No, thank you for asking that question. And we do come across many patients who are facing legal issues, especially when they've lost income and they're receiving eviction notices, for example, or they're being asked to leave their place of employment. We do have a few legal organizations on our resource list that we reach out to, but we don't have a formalized partnership with a legal organization. So I would love to be in touch with you and see how we can formalize a partnership. Yeah. Thank you. Enjoy the coffee.
So we're now at a point for our coffee break, but I just want to, before we transition to our break, just thank the presenters for really illustrating some, I think, really important lessons that have been learned as they've launched their patient navigation programs, work to develop policy, and sort of help us think about some of the evidence and data that are needed to really facilitate and make sure that we continue to make progress. So when we come back from our break at 2:45, we're going to hear from Trish McDade O'Neill, who is the Director of State Government Affairs for AstraZeneca, and also from Brooke Burnell, who is the U.S. Oncology Inclusion and Diversity and Health Equity Lead, also at AstraZeneca. And that's really will be important because we now want to sort of move our conversations like what we can do at the state level, at the policy level. Remember to scan the QR codes to share your thoughts, help us recall what lessons you're taking away. So because that will be the conclusion of our day, is sort of how we transition and move what we're talking about today into action. All right, thank you.